All right, welcome to The Explainer. Today we're diving into something you're absolutely going to see, both in the clinic and on your exams: inguinal hernias. Let's demystify this, shall we?
Okay, let's set the scene. You've got a patient, and they have a bulge in their groin. You're pretty sure it's a hernia, right? But the real question, the million-dollar question is, what kind of hernia is it, and how can you be absolutely certain? Because getting this right, that changes everything.
Well, you guessed it. The key to cracking this case, like so many things in medicine, is all about the anatomy, the inguinal region. It's just a natural weak spot in our abdominal wall, an area that's kind of primed for things to, well, bulge out. So let's get in there and take a closer look.
To solve our hernia mystery, we first need to map out the key structure involved, the inguinal canal.
So, what is this thing? Just picture a short, slanted tunnel, maybe about 5 centimeters long, running right through the lower layers of your abs. It's got an entrance, an exit, and 4 walls. And each wall is built from a different layer of muscle and fascia.
Okay, this is where it gets really interesting. Let's break down how it's built. The front wall, the anterior wall, is formed by the external oblique aponeurosis. Behind it, the posterior wall, is the transversalis fascia. Up top, the roof is made of these cool, arching fibers from the internal oblique and transversus abdominis muscles. And holding it all up from the bottom, the floor, is the super strong inguinal ligament. You see how it's all layered?
So what's actually traveling through this tunnel? Well, that's where things get different for males and females. In males, it's the spermatic cord, that whole bundle with the ductus deferens, vessels, and nerves. But in females, it's the much smaller round ligament of the uterus. And that single difference right there is the #1 reason why inguinal hernias are way more common in men.
Okay, so we've got our map. But to really tell the hernias apart, we need to find one single critical landmark. This is the clue that cracks the whole case wide open. Seriously, for just a second, forget all the other details. If you want to know what kind of inguinal hernia you're dealing with, you need to ask one question. And it all has to do with where the hernia is relative to a specific pair of blood vessels.
And here they are, the deciding clue: the inferior epigastric vessels. These guys run up the inside of the front abdominal wall. Think of them as a dividing line, a literal line in the sand. Is the hernia starting medial to them or lateral to them? That's it. That's the whole game.
All right, so if those vessels are our dividing line, let's look at the area medial to them. This is a notoriously weak spot called Hesselbach's triangle. You can think of it as the scene of the crime for direct hernias. And why is it weak? Simple. In this spot, the back wall is basically just that thin transversalis fascia. There's no big muscle layered on top for extra support. It's a prime target for a bulge.
Okay, pen and paper time, because this is super high yield for any exam. What are the borders of this triangle? Medially, you've got the edge of your rectus abdominis, your six-pack muscle. Laterally, there they are again, our all-important inferior epigastric vessels. And along the bottom, the floor, is the inguinal ligament. You gotta know these 3 boundaries cold.
Okay, so we have our landmark, we found the weak spot. Now we can finally put it all together and nail the diagnosis. Let's identify the 2 culprits: direct versus indirect hernias.
And boom, here it is, all laid out. An indirect hernia starts lateral to the vessels and travels down the entire inguinal canal. A direct hernia starts medial to the vessels, just busting right through that weak Hesselbach's triangle. See, it really is all about medial versus lateral. And this also explains why those indirect hernias are the ones that can end up way down in the scrotum, while the direct ones usually don't.
So how can you remember this? Think of an indirect hernia as taking an old, pre-built road. During development, this little tube called the processus vaginalis goes down into the scrotum with the testes. It's supposed to close up after birth, but if it doesn't, bam! You're left with a ready-made path from the abdomen right into the inguinal canal. That's why we call it congenital.
All right, let's test this knowledge with a classic board-style question. A surgeon is fixing an indirect hernia, and they point out the internal spermatic fascia. So the question is, where did that layer originally come from? Which layer of the abdominal wall did it start as?
The answer goes right back to that developmental journey. As the testes descend, they literally drag the layers of the abdominal wall down with them. It's just like pulling your head through a turtleneck. You pull the fabric with you. So the deepest abdominal layer, the transversalis fascia, becomes the deepest covering of the cord, the internal spermatic fascia. It's a perfect one-to-one mapping. Pretty cool, right?
Okay, we've been deep in the anatomical weeds. Now let's pull back and lock in the high-yield clinical takeaways. This is the stuff you absolutely need to remember for the wards or your exams.
First, just look at this number. 86%. A whopping 86% of all inguinal hernias happen in men. And now you know exactly why, right? It's a direct consequence of that spermatic cord creating a much bigger potential weak spot than the round ligament ever could in females.
All right, here's your ultimate clinical cheat sheet. For an indirect hernia, think infant or young person. And remember, it's lateral to the vessels, so indirect is lateral. For a direct hernia, think older patient with an acquired weakness. And remember, it's medial to the vessels, so direct is medial. Got it? That's the core of it right there.
Which brings us to our final crucial thought. After all of this anatomy, all the embryology, it all boils down to one simple question you should ask yourself when faced with this exact clinical scenario.
And that question is simply this: is the hernia medial or lateral to the inferior epigastric vessels? That's it. Answering that one question, based on that one key landmark, is the starting point for your entire diagnosis. It unlocks everything you need to know.